unipolar major depression patients. They insert an electrode into the brain, and it's, well, I don't have a drawing here, but if you imagine a brain sliced in half, and this is the head, the corpus callosum curves here, and the area is like right about here. And so they put an electrode there, and it starts, and they have a stimulator that's implanted, and they start stimulating it. And when I was talking to her one time, it was really pretty amazing. She said that I believe they did, the first group was like 7 or 8 patients. About 3 or 4 of the patients, when they turned on the stimulator, said that it was as though the lights had been turned on in the room, and their depression just immediately vanished. That's pretty impressive because, I mean, it sounds, of course, there are some risks with inserting an electrode in the brain, but it's not that risky in terms of everything put together. She did some interesting positron emission tomography studies, or PET studies, where she compared deep brain stimulation to paroxetine or cognitive behavioral therapy. And so basically she looked at the regions of glucose metabolism in the brain, which is what PET is used for, before and after each of the treatments. So she could see the changes associated with paroxetine, the changes associated with deep brain stimulation, and the changes with cognitive behavioral therapy. And it's pretty interesting because paroxetine and cognitive behavioral therapy look quite different in terms of their effect on people who responded. And the interesting thing is that deep brain stimulation literally looked as though you took the other 2 treatments and put one on top of the other in terms of the areas of the brain that changed in people who responded. So aside from the technological issues of actually putting the electrode in, it's really quite an interesting technique that could be pretty valuable in the future. So just to wrap up in terms of what medications are available, there are two medications that the FDA has approved for the treatment of bipolar depression, and both of them are what we refer to as second-generation antipsychotics. One's a combination of olanzapine and fluoxetine, and the other would be quetiapine. Although this slide says that some antipsychotics don't work, and I really never disagree with Dr. Altshuler, so this must be a typo. And, and so what she meant was some antipsychotics don't work by themselves because they're meaning ziprasidone, and there's no evidence, ziprasidone certainly doesn't, there's no evidence that aripiprazole or Abilify does. But there is evidence, and Abilify was recently approved as augmentation for the treatment of bipolar depression. So in other words, you can add Abilify onto an antidepressant, and that can, actually I think that's major depression, not bipolar depression, excuse me, but that can actually be helpful. Some mood stabilizers can be helpful with depression, namely lithium and lamotrigine. Valproate doesn't seem to be as helpful, neither does carbamazepine. And it seems that antidepressants can be effective adjuncts if patients are on lower levels of lithium. But as I said before, since we know that lithium and some of the other second-generation antipsychotics have antidepressant properties, it's possibly likely that adding an antidepressant doesn't give you too much. There doesn't, aside from tricyclic antidepressants, there doesn't seem to be an increased rate of switching from depression to mania when administering an antidepressant in bipolar disorder. And so that's where we'll wind up today. So we have some time for questions. Actually, I think.
Hi, my daughter has been taking Wellbutrin for many years, but went through a rough year a couple of years ago, and it turned out she'd been getting the generic Wellbutrin. And the minute she switched, she improved.
Switch back to the branded?
Yeah, can you offer any insight to what's going on there? Because it's really hard to get it through CVS and write it, because they require you take the generic if you possibly,
Oh, you mean the insurance company?
Yeah. Yeah.
In terms of the generics, many generics, because of the way they assay the different generic drugs, there can be some variation between that and brand names, and usually the doesn't make a difference. The only medication where there was a significant... There we go. Sorry. That there was a significant concern about that was clozapine, which is an antipsychotic used in schizophrenia. And when they released the generic of that, there was a lot of concern that the generic was nowhere near as effective as the branded one. And so a lot of insurance companies and at the VA would allow patients to switch back to the branded one if they immediately changed after going off. In terms of bupropion in particular, I don't know of any reports, but it is a concern by many people that the assays for generic medications may not have quite as tight of a window as for the branded ones.
I would ask a question.
Sure.
You have not mentioned Abilify for
That's aripiprazole?
treating bipolar, and I know someone that's doing extremely well on it.
Right.
Lithium, and so I was wondering what you mentioned.
Well, I was focusing on the treatment of bipolar depression. Abilify is approved for the treatment of bipolar mania, and it works very well for that. And quite commonly, when it works for that, you can continue to keep people on it because Abilify has very good mood stabilization properties. In addition, it's also been shown that it helps, if you add it to an antidepressant, it helps the antidepressant activity. So a lot of people with bipolar disorder who I've seen, I give them Abilify, and they can do very well on it. A lot of the choice of medications really depends on what each person tolerates, because unfortunately in psychiatry, we don't have any tools to determine what medication is going to be best for a given person. We can make a broad generalization, and then we can use our clinical skills to make the best approximation. But unlike internal medicine, where we can sometimes you can do a blood test and say this is the bacteria and this is the antibiotic, unfortunately we don't have that. Abilify is effective for bipolar disorder, and it was just that it's usually considered mostly in terms of treatment of acute mania, and it also has a maintenance indication, I believe. So it's not its indication for depression. It's more as an adjunctive agent. Right, some people, well, lithium's an effective drug, but for some people they don't tolerate the side effects very well. And again, even though two medications in studies, you may have thousands of patients, and maybe you say, well, each of them led to the same percentage of people getting better. For an individual person, they may respond much better to one medication than another.
I'd like to ask you a question. His long-term memory, he's like a genius, but his short-term memory is really sad. Would the medication have an effect on short-term memory?
Usually with Abilify, it's thought to help improve memory and help improve cognition some. Sometimes with lithium, you might see a bit of a problem, or more commonly with Depakote or valproate, you see some short-term memory difficulties because it tends to make people a little cloudy. Usually, though, Abilify tends not to do that. I mean, it could, but it's yeah, it usually doesn't, but it could. Yeah. That's one of the paradoxes with lithium is you get a fine tremor when you take it, and then if you take it for a long time and then go off, then sometimes the tremor gets a little worse. But that was just probably part of it. Usually with Abilify, the more common thing would people would feel a bit restless. But lithium will give you it's hard. I can't really do it very. You get a very fine resting tremor, which is pretty common from lithium.
Do you have anything to say about Lamictal?
Lamictal, I'm sorry, I didn't use the trade name for that. That's lamotrigine.
It is.
Yeah, I'm sorry.
Okay.
I try to be unbranded, but throw in the
Okay.
branded names because I know that it depends on what people hear. Once a medication goes off patent, then you never hear the brand name again. But when it's on patent, the drug companies make sure that's the only thing you hear. But lamotrigine and Lamictal are the same thing. It's just lamotrigine Lamictal is now off patent, so you can buy it generically, so it's less expensive.
And does it,
I'm sorry?
and
That's what she had asked, and for most medications, no, I haven't seen a difference.
and it's helpful for depression?
Mm-hmm. It's approved for maintenance, which is kind of an odd issue. And actually, Terry Ketter and I were working on a paper to help determine when it's actually beneficial to start it. Because you can say, well, lamotrigine or Lamictal will help keep you not depressed. So FDA says, so that's why you take it. Well, that's fine. So when do you start taking it? When you're depressed? When you're not depressed?
It says not to be used if you're experiencing as a
Right.
cure for depression.
Right, that's because it wasn't approved that way, but there are studies that suggest that it actually does help with depression in addition to the maintenance.
Secondly, if anybody here, or if you know of a support group, I'm in desperate need of one for depression or bipolar.
Probably, I don't have the list offhand, but I imagine someone would. If you go, I think through usually NAMI will have a lot of, NAMI, National Alliance for Mentally Ill, NAMI. That's usually a very good resource. Oh yeah. That's usually a great resource. I think she was next. I didn't want you to be ignored given that you're right in the middle and on the front.
Thank you. Is it on?
Yeah.
One of the things I found most helpful today was this is the first time with all that I've read about bipolar over the last 10 years that there has been a distinguishing characteristic between the depression of bipolar patients and just regular depression and the drugs that you've used.
Right.
And so is this a widely known fact among psychiatrists, or are they just going, because I have had different experiences where they're just giving out drugs, you know, Cymbalta, Effexor, all these different drugs, and acting as if the bipolar depression is the same as any other depression.
It's not the same. I don't know how widespread the knowledge is because, as I said, it's been something that's been unfortunately neglected, in the field, because you have to have different. You have to be aware of different issues in bipolar disorder. For example, switching. If someone just has major depression, you can give them a tricyclic antidepressant, such as Elavil, and if they stay awake, they can move their bowels, and they can keep their mouth wet, they'll get better, and they're not going to become manic. However, if the person's bipolar, you have a pretty significant probability that you're going to take someone from depression to mania, and that can be very dangerous.
Well, that part I know, and they're aware of that,
Right.
at least. So let's say they put them on a mood stabilizer, and like I know for myself, I was put on a mood stabilizer like Topamax that's now been found to be worthless.
Right.
But it helped with my migraines, so that was fantastic. It was a miracle.
You got something, so that's something.
Right.
At least you just didn't get side effects.
Yeah, so let's say somebody else was put on Lamictal and Cymbalta, which was turned out, not to be that great, and a very, very high dose of Cymbalta. Obviously, that's not going to work.
That probably, the Cymbalta would probably not be necessary, and you would run a risk of just getting side effects from the Cymbalta without additional. Because of the effects of, the studies tend to show that if patients are on a mood stabilizer that helps with depression, adding an antidepressant on top of that seems not to give that much extra boost in terms of antidepressant activity.
Or could send them into mania, which is what it seemed to do.
I'm presently on Lamictal, and which is spectral, and at first it seemed to work, and I find that with mine that it worked, and then they changed it, work.
Sometimes it requires titrating doses or adjusting medications over time. And we're not, because it's not exactly clear why all the medications, what they exactly do, it's really hard to say, what needs to be done. As an example, some of the work that I started on before I came to UCLA and I continued with Dr. Altshuler is we found that in bipolar depression, the brain actually changes its structure. So it's not just changing where it's metabolizing glucose, like some areas don't just become less busy. The gray matter actually changes between the depressed states and when people are not depressed. We don't have the data for mania because I did one study with manic patients in a scanner, and that was a lot of time. that was really early in my bipolar research career. It was a wonderful study, but I'm not going back there.
What happens when you have bipolar 2, when they've got this type of condition, and you just stay depressed? You don't feel like you don't go down, you just stay depressed.
Well, some people, there are a lot of different things people can do at that point in terms of augmenting it. For example, depending on the person, one strategy, some people would suggest trying different stimulants, because that's one thing that can be used in refractory depression. Depending on the extent of the depression, electroshock therapy is very effective, and actually the shock therapy itself has very few, if any, risks. Most of the risks come from the anesthesia that's administered along with it. But that can be very effective too. Depends on what people have had full medication trials of. Depending on, again, how much it's affecting the person's life determines how aggressive you go into different treatments. If it's prolonged and really not and there have been trials of multiple antidepressants, then electroshock therapy is one of the options.
Can you sort out the difference between bipolar disorder and bipolar 2, particularly in lifestyle issues? I mean, how bad your illness is going to be if it's a bipolar 2, for example?
In terms of what happens with them?
What happens?
Yeah, the issue is mainly, since both bipolar 1 and 2 have periods of depression, the issue would be with hypomania. So if you think of it as kind of, the cut point between hypomania and mania is kind of hard to verbalize. I mean, people with hypomania don't hear voices and aren't as grandiose. They usually have a lot of energy. They're often give the impression that they're, fun to be around. They're usually pretty effusive, and they can actually, if the hypomania is not severe, they can get quite a bit done, and they're pretty busy. When it starts tipping into mania is when you have a much decreased need for sleep. Hypomania, you may have some decreased sleep, but not like mania, where people can go for 4 or 5 days without sleep. Hypomanic, during periods of hypomania, people tend not to, they're usually not as likely to be irritable as people during